for this session, the chairpersons are Professor Vinita Singh, ma'am. Are you there? I can't see ma'am. Dr. Namrata had called me up that she had another session because we were running late. So she said she's going to join the next session, other session of hers, and then she'll come back to us. So let us start with the first talk here, Management of Pediatric Cataract by Professor Reena Gupta. And she's there. Dr. Reena, off to you.
Hi, good afternoon, everyone. So I'll be sharing my screen.
Hello, Ankur. I'm very much there.
Yeah.
Only my unmute button was not working.
Thank you, ma'am. Thank you, ma'am. So let us just move forward for the next session.
It was not working for some time.
Yeah.
Kind of it was it hanged.
Yes, we can see you, ma'am, now. Yeah. Dr. Reena, I think you should start your presentation, and I'll request everybody to stick to the time. In fact, try and finish up a couple of minutes early so that we can catch up with it.
Yeah. Can you see my screen?
Yes, yes, very much. Yes, very much.
Thank you. At the outset, I would like to thank Dr. Shukla sir and Dr. Shreya for this opportunity. So for a successful pediatric cataract surgery, we need to be an experienced phacosurgeon, adequate knowledge of IOL calculation, management of amblyopia, and post-operative complications have to be there. We should have access to infrastructure, especially the vitrectomy facilities, and the aim is a long-time clear visual access. So a dense central congenital cataract, which is more than 3 millimeters in diameter, associated with strabismus and nystagmus, are the indications for urgent surgery. When should we operate? Now, these infants have to be operated between 4 to 6 weeks. If we operate them before 4 weeks, there are risk of anesthesia-related complications, the chances of development of secondary glaucoma. And if we operate them after 8 weeks, then the chances of incidence of strabismus, nystagmus, and amblyopia. So keeping this in mind, the ideal time would be for unilateral cataract before 6 weeks and for bilateral cataracts before 8 weeks. And for bilateral cataract, it is better to do a sequential surgery to avoid the risk of endophthalmitis. Now, we should start with a detailed prenatal birth and family history. A thorough ocular examination is must, and fundus examination has to be done. If it's not visible, do a B scan to rule out the posterior segment anomalies. And especially in children with unilateral cataract, it's important to rule out PHPV. Then for infants with bilateral cataracts and congenital cataracts, they have to be referred to a pediatrician for a thorough examination to rule out the systemic anomalies and metabolic disorders. The baseline laboratory workup should include the torch titers, urine analysis for reducing substances, and serum blood sugar and serum calcium for most of the cases. Now, the parent counseling is a very important step. They have to be told that surgery is the first step. It has to be followed by frequent follow-ups, and the compliance for spectacles and some compliance for amblyopia treatment has to be there for a successful visual outcome. IOL power calculation in children is a challenge because it depends upon a number of factors like the age of the child, the keratometry and the axial length measurements, which grow rapidly during the first 6 months. And also, these have to be taken under general anesthesia. We do not have a customized formula for IOL power calculation in children, though there are different study groups which have claimed that the prediction error with SRKT2 and Holiday 2 are quite comparable, but there is no single formula with the accuracy. So how much should be the undercorrection? See, we all hope that there's emetropia of the child when he reaches 6 to 8 years of age. And we know that the myopic shift is also happening at the same time. So we need to undercorrect. Now, there are different formulas by NID and Dahand, which are quite popular. But with time, the surgeon, they devise their own nomograms depending upon a lot of factors. And also there's another school of thought that the undercorrection should be less so that you have less residual hyperopia, which is also amblyogenic. Pediatric cataract surgery is a challenge even for the best of surgeons because these pediatric eyes are very different. All these children have to be taken up under general anesthesia. The deep anesthesia is mandatory throughout the procedure to prevent the positive vitreous pressure. Usually, I prefer clear corneal superior incision to prevent the wound exposure. And also, all these incisions have to be sutured to prevent the wound leakage. Anterior capsular rhexis, which is the most essential step for a favorable visual outcome before proceeding to anterior capsular rhexis. If the pupil is myosed, like you get in most of the infants, you should dilate it with a preservative-free diluted adrenaline, and also a cohesive viscoelastic like Hilon GV is very useful. And if it's not available, then sodium hyaluronate is also a good alternative. For the adequate visualization of the capsule, it has to be stained with trypan blue dye. Now, the different techniques which are available for the anterior capsular rhexis are manual CCC, which is the gold standard, though it has its own learning curve, vitrectorhexis, and fugoblade is useful in cases where there's a PHPV associated. Femtolaser is the latest technology which has been established for doing anterior as well as posterior capsular rhexis, but there is incidence of radial tears which are reported. Zepto is the new kid on the block, and it's still not published in pediatric surgeries. So I go for a manual CCC, and for this you have to inflate the anterior chamber first with the cohesive viscoelastic to flatten the capsule since it's very elastic in children. Give a nick with the cystitome, and once the flap is raised, grasp it with the microrhexis forceps. Always the shearing force has to be directed centrally so that you have a round, continuous, adequately sized and circular anterior capsular rhexis. Now, the different morphologies for pediatric cataract, right? So you can come across a case of PHPV where you have a fibrous capsule. You can come across an intumescent cataract, a membranous cataract in patients of congenital rubella syndrome, or traumatic cataracts. So in these, the morphology of capsule is also very different. So you can use a retinal scissors if it's a fibrous capsule, or in cases of PHPV, even vitreous cutter helps to complete the rhexis. Multi-quadrant hydrodissection is usually preferred in children, and be careful with the hydrodissection in cases where you're suspecting a posterior lenticonus or posterior polar cataract. Now, cortical cleanup has to be very thorough. For eye and A, you have a bimanual technique and also a coaxial technique. I prefer a bimanual technique for a thorough cortical cleanup. Coming to the posterior capsulotomy, in order to reduce the incidence of visual axis opacification, it is mandatory in children less than 6 years of age. Also, if the child has nystagmus, you can do it in older children as well. So posterior capsulotomy can be done in the same technique like you do anterior capsular rhexis, but you should prefer a ILM peeling forceps since it has a longer length. It gives you better grasp. And once you have inflated the cohesive viscoelastic and given a nick, just grasp it with the rhexis, and again the force is directed centrally, but here you need much more force and it has to be vertically oriented force. Now you can do it manually also as well as with cutter, but my personal experience, I find manual is much more regular and the chances of extension are quite less. You might come across posterior plaques in such cases, and the posterior plaques can be easily removed with the help of a needle, or if the density is it's very denser, then it's better that you can remove it with the help of a cutter. Coming to the anterior vitrectomy, all posterior capsulotomies have to be followed with anterior vitrectomy. I use a 23 gauge cutter and a cut rate of 1500 with the low suction pressure. And the port has to be directed posteriorly. The end point is that there has to be no residual tags in the anterior chamber, for which I personally use Canacot because triamcinolone helps you in the visualization of these tags, and also it is anti-inflammatory. So once you have completed the vitrectomy, it's better that you use an iris repositor and sweep it across to check for any residual tags. And then you can direct the port anteriorly and remove it. Nowadays, there are techniques by Gimbal group, which has said that you can do optic capture and you don't need to do anterior vitrectomy. For optic capture, you have to capture the optic behind the posterior capsular rhexis. For this, you need very precise measurement of the anterior and the posterior rhexis. Also, there's a lens design bag in the lens, which has been advocated by Tassignon and group, that this lens reduces visual axis opacification without going for vitrectomy, and it just needs that both the rhexis margins have to be hooked in the groove, which is present in the lens design. Coming to primary IOL implantation, it is widely practiced over 2 years of age. But if you look at less than 2 years, it's, especially the infants, then if the corneal diameter is less than 10, if the axial length is less than 17, and if the age group is less than 6 months, it's no for me. Because I've seen putting IOLs in less than 6 months of age, it gives you a very high refractive surprises. The incidence of postoperative inflammation is also more in these cases. So for children, we prefer a single piece hydrophobic acrylic lenses. These can be implanted under the fluid or under a cohesive viscoelastic. The technique is that when you're dialing the leading haptic, you should always press it against the back surface of the anterior capsular rhexis, and the trailing haptic has to be it has to be tucked in the back. So it has to push down towards the back. In cases of traumatic rupture, like this was a case of trauma in which there was a capsular band which was left. So this band was basically used as a scaffold and the IOL is implanted behind the band. Coming to secondary IOL implantation, if you let the child a phakic, and this is quite safer. The rates of post-operative complications have been reported to be quite less with secondary IOL. And we are quite well versed that when you're planning a secondary IOL, we just have to clean the visual axis with a cutter. And if there is a bag, you can put a single piece. Otherwise, for sulcus, you need to put a 3-piece, and PI is must. Now, amblyopia is a problem. Already everyone has discussed about amblyopia. We know that it is very prevalent and denser in unilateral cataracts. So I would stress that visual rehabilitation has to be initiated within the first 2 weeks after surgery. If it's a bilateral cataract and you're planning a spectacles, the problem is going to be it's very thicker and heavy. So for that, always use a headband so they're positioned properly. And don't forget to prescribe the near dominant glasses to these children. Also, if it's a unilateral cataract and the parents are literate, they are okay with the safety and the convenience of the contact lens, this is a better option, keeping in mind that it reduces the retinal disparity much better way. So pseudophakics, like Dr. Garka ma'am also said, that you have to prescribe the near dominant glasses if the children are less than 2 years, or bifocals if they are more than 2 years of age. Coming to the amblyopia patching treatment, it has already been discussed. These are the schemes which we usually follow.
Dr. Reena, I'll request you to summarize, please.
Concluding, yeah. So in some patients, what happens there, the prognosis is guarded. So for these patients, low vision aids can be helpful to use the remaining vision more effectively. This is the last slide. Coming to the post-operative complications, glaucoma, especially the phakic glaucoma, has been reported in children who have been operated in the first 4 weeks of age. I have a study of around 40-50 eyes in which they have been followed for 4 to 5 years, and have found that the incidence of visual axis opacification, it is much more if we operate these children and plant a IOL in the first 6 months. Otherwise, if you do a meticulous surgery, adequately sized posterior capsulotomy and anterior vitrectomy, visual axis opacification incidence is not much. Similarly, about myopic shift, I would say that the incidence is much more, and high myopias have been seen in children who are operated in the first 6 months with the IOL implantation, and also more so in children with unilateral cataract.
Conclude, please.
Okay, sir. So last slide to conclude, I would conclude with the saying, chance favors the prepared mind. Thank you so much.
Thank you.
Thank you, Dr. Reena. The next talk is by the organizer of this lovely conference, Dr. Shreya Shah. She'll be talking on overview of golden hour syndrome. And over to you, Dr. Shreya Shah. By the time she starts, I'll just add one more thing. Like, people have started adding gonioscopy as a part of doing pediatric cataract surgery, because a lot of the times we have some common factor, which is development of cataract as well as glaucoma. And the incidence of glaucoma following a cataract surgery is a separate category in the part of pediatric glaucoma, where the incidence of glaucoma can be as high as 50% of patients who are operated for congenital cataract surgery. So that helps us to find out whether it is a pre-existing glaucoma or a glaucoma as a result of cataract surgery.
Yeah, I think Dr. Ankur, I just missed it because of time. That otherwise, a slit lamp examination has to be done to rule out anterior segment dysgenesis. That's very important. Yeah. Thank you.
Specifically talking about the angle dysgenesis, because anti-segment dysgenesis may not be there, but subtle angle just may still be there before the surgery. So over to you, Dr. Shreya. Nice organized conference, Dr. Shreya.
Thank you so much. Am I audible?
Yeah, definitely.
And are my slides are visible?
Yes, absolutely.
Yeah, thank you so much. Thanks, Dr. Shukla sir, to allow me to speak on very, very rare topic. It's a golden heart syndrome, which is an oculo-auriculovertebral dysplasia, well described by Maurice Goldenhar in 1952, with a neural crest division disturbance or first or second branchial arc disturbance, can lead to maldevelopment of certain features. These are the chromosomal defect we can find in golden heart syndrome. Sometimes external factors also can play a role, like maternal ingestion of Accutane during second trimester or second trimester bleeding, gestational diabetes mellitus, or any other things like multiple pregnancy or assisted pregnancy. So we look into the literature, what we saw out of it is the incidence is 1 into 3,500 to 1 into 5,600, but out of our total pediatric OPD 4,10,000, we saw that 48 patients were having a clinical features of golden heart syndrome. So all of them were retrieved from our HMIS and exported to analyze with the SPSS 22 software. Again, literature says that 70 to 75% are unilateral cases, but in our series, nearly 90% were a new unilateral disease. Male-female ratio, according to literature, is 2:1, but in our series, we found nearly equal. Age of presentation can be any ranging from the first day of life to adulthood. In our series, we found 19 presented before 5 years of age, 25 presented between 6 to 18 years, and 4 presented after 18 years of age with clinical features like ocular abnormalities, auricular abnormalities, vertebral abnormalities, sometimes may be associated with facial, CNS, cardiac, and other ENT abnormalities. But majority of things concerned with our ophthalmologist or ocular science, which is upper lid coloboma associated with iris or chorioretinal coloboma, epibulbar choriostoma, and less frequently sometimes we find microphthalmia, anophthalmia, strabismus, or in different interpalpebral features. Again, we look into our series, we found almost everybody had either limbodermoid or lipodermoid, along with pre-auricular appendages. Some were having microphthalmia, lid coloboma, malformed ear, and mandibular hypoplasia. And most of the people presented with oval dermoid. If you look into investigation, not much of investigation required because it's a very typical phenotypic appearance clinical feature, but we may ask them to go for CT, MRI, or sometimes genetic test to help to support the diagnosis. In prenatal accurate ultrasonography sometimes may reveal the defect what is there. But nowadays, anterior segment OCT will reveal extent of disease as well as the part of disease, and confirmation can be by topography. These are my differential diagnosis also. And if you look into management, it's a purely with age and systemic association. The first and foremost thing for management is therapeutic management when you are expecting corneal ulcer. So cornea has to be protected first, like in this baby, first day baby, you have to, it's a surgical emergency in order to protect the cornea from ulceration, perforation, leukoma, or amblyopia. And if we are looking into the elite coloboma disease management, we have to follow the quarter rule. So lack of the substance equal to 1/4 of the length of eyelid does not alter the static, dynamic, and functional aesthetic of the eyelid. So direct suture can be possible when there is 25% of the lid coloboma. Don't forget to properly suture the lid margin. Can be follow 5-3-3-5 rule diagonal suture, or can just follow the gray line suture. Don't forget to bury long ends into the wound. So this is the, sometimes we have to operate baby in a 2-3 sittings. So I just remove this part and then we operated for the coloboma. This was directly done because it's less than 25% of coloboma. But sometime if it is more than 25%, we may have to put tensile semicircular flap along with the direct removal of the coloboma. So after making the raw area of coloboma, you have to put extendable tensile semicircular flap, and don't forget to do proper canthotomy and cantholysis. As I said, in direct suturing, we can suture the wound, then we have to suture properly the semicircular flap. If it is more than 35% defect, tarsomarginal graft, Cutler Beer technique, or mustard technique and Huggies technique are possible. In tarsomarginal graft below 2 to 3 millimeter of the lower lid margin, we can put the incision. We just separate the conjunctiva and tarsal plate, and we can attach this conjunctiva and tarsal plate of the upper lid, and then we can suture it with upper lid conjunctiva tarsal plate, and then we can do skin grafting. So this baby was operated for tarsomarginal graft. Cutler Beer technique is also called as a bucket handle technique, but then we have to take care of amblyopia management because we are keeping the eye closed for 8 weeks of the closure. Modified Huggies technique sometimes they can correct 70% of defect, and mustard flap rotation is mostly done by lower lid coloboma. But these are definitely an emergency, and we may have to sometime use amniotic membrane, maternal oral graft, donor scleral graft, and maternal skin to cover to make the lead. The epibulbar dermoid is the hallmark of golden heart syndrome. Can be soft elevated, localized yellow white tissue can most of the time present at lower temporal, but can present at upper lower nasal also, and can have sometimes hair on it. Management depends on the grade. Grade 1 is simple limbal dermoid with very superficial involvement of cornea. Grade 2 is full thickness involvement, may or may not be associated with endothelial involvement. And third, grade 3 may be, there may be some defect in anterior segment also. So after proper dissection and evaluation of limbal dermoid, proper dissection should be done. There can be a blunt as well as the sharp dissection to remove the limbal dermoid as whole. So sometimes we may have to use blunt and sharp techniques both. Don't forget to remove the dermoid as a whole. And then remove the rest of the tissues also. And send for HP, which can confirm the diagnosis. It is limbal dermoid. This was a patient operated by simple excision of limbal dermoid. But when you have grade 1 limbal dermoid, you can just suture the conjunctiva. Not much of a corneal opacity is seen. And even if it is seen, we can just fix it with cosmetic contact lenses. But what about this kind of patient who has grade 2 and grade 3? After removal of dermoid, they'll definitely leave a dent. So we have to correct it with penetrating keratoplasty or lamellar sclerokeratoplasty. Sometimes we have to go pericardial graft, patch graft, or multilayered AMG. So after removal of the limbal dermoid, we usually polish the area what is left on that, so to make it properly smooth, and then we can put one layer of AMG. But sometimes this is the baby operated by one layer of AMG, first day post-op and first 1 month post-op. But sometimes one layer is not sufficient. The dent is such a big and deep, so you have to go for sometimes multiple layer of AMG to cover the astigmatism, in order not to get much of astigmatism. So 1, 2, 3, 4 layer we may apply for the from the amniotic membrane. This is the lady operated for a multiple amniotic membrane. Sometime after removal, we can do anterior lamellar keratoplasty, but after keratoplasty, we are suturing, so we may leave the suture mark on the cornea. So nowadays, people are doing, after removal of the graft, we can just attach the corneoscleral graft through glue, so which will not leave a suture mark. But what about this corneal opacity? So we may have to do sometime tattooing of the cornea with the dry powder, which is available in market. Then 2 or 3 diopter smile lenticule we can attach over it, that will take care of the cosmetic correction. So we are at Drashti Netralayah do LASIK, but I have taken my colleague's video to show you the option. This is the lady operated for that. So these are certain post-operative results. Let's talk about lipodermoid. Again, is a strikingly more yellowish feature, but sometimes present as elevated or simple flat mass, or can be extended to the medial canthus also. Can present at any gender and any age, can be presented bilaterally, or sometimes may be associated with some other lead deformities. So can present at any age, and sometimes babies, they can present with along with uriblaferon also. If you look at the extent, it looks very small, but we press, it's too much. So that doesn't mean that just keep on pulling the fat from the orbit. Whatever is necessary, that much we have to pull, because we have to save lateral rectus muscle from scarring also, and from inophthalmos also. So after that, we have to put the amniotic membrane graft. This is 15-year girl, had typical lipodermoid, mandibular hypoplasia, and preauricular tech, typical golden heart syndrome, had both lower fornix and upper fornix lipodermoid. This is first day of post-op, first month post-op, and 2 months post-op. Same, the elevated lipodermoid was operated first day, first month, and 2 months post-op. Can be operated bilateral in a single sitting also. So my take-home message is surgical treatment is mandatory, and sometimes complex patient may require multidisciplinary approach. So what we look at the result of our 48 patient of limbal dermoid, significant difference found in pre and post-operative vision, significant difference found in pre and post-operative refraction of the patients, but no significant difference found in visual outcome as compared with according to the shape and area of the disease. So epibulbar choriostoma should be excised in very early years of life in about to order to avoid the amblyopia. Some astigmatic changes are always expected, so frequent refractions are must. Lipodermoids are not an emergency. Long-term follow-up is necessary for all kinds of babies, paying increased attention to post-operative care to avoid the amblyopia, astigmatic changes, and wound dehiscence. These are my references. Thanks to my patients. Thanks to my teachers. Thank you.
Thank you very much. Thank you very much, Dr.
Thank you, Dr. Shreya. The next talk is by Dr. Fatima Yulek. She is the international presenter here, and she'll be talking on clinical picture and diagnosis of oculomotor. I think it should be paralysis, not neurons.
Dr. Fatima is logged in.
Yeah, I think she's there.
Okay, just to give a little introduction, Dr. Fatima Yulek is a professor at Ankara Medical College in Turkey, and she was with us in the midterm also, and now she is with us at the annual also. We welcome you, Dr. Fatima. Dr. Fatima, can you hear us?
I think so. She's muted. Ma'am, you need to unmute yourself. I think you're muted. Dr. Fatima, you're muted. Please unmute yourself.
Okay.
Yeah. Now we can hear
Thank
you.
you very much.
Good afternoon.
Good afternoon from Ankara, Turkey.
Yeah, welcome again.
It's a pleasure for me to see all you again. Wonderful meeting, fascinating presentations. I should present my thanks to Dr. Shukla and to the SPOSI organizing committee for their invitation to this meeting. It's an honor for me to present here. I want to share with you my experience with some isolated schwannoma cases. I will start with one case that I have seen initially. Why I present this? Some cases of progressive acquired strabismus are categorized as idiopathic without identification of etiology. Isolated schwannomas of cranial motor nerves are among these underdiagnosed cases. Partial cranial nerve palsies with atypical presentations can be easily missed. Pardon me. There we go. I had this patient about 1 year ago. This 37-year-old male presented with acute left third nerve palsy. At his initial presentation, the left eye was completely ptotic. And therefore, I couldn't take his images. And I was able to take the images after partial resolution, as you see here. There was up gaze and down gaze limitation and adduction limitation. He had headache at the same time. And in his medical history, migraine headaches and a similar episode when he was about 9 years ago, was present, but that attack lasted about 15 days, he said, without any sequela. Unfortunately, he had also a viral conjunctivitis concomitant with this third nerve palsy of the left eye. Initially, we focused on painful ophthalmoplegia causes like tumor, infection, thrombosis, and ophthalmoplegic migraine, which is called simply recurrent ophthalmoplegic cranial neuropathy. About 3/4 of the recurrent cranial neuropathy cases have focal enlargement and contrast enhancement of third cranial nerve during the acute attack, but the nerve is completely normal between the attacks. And 93% of the cases involve the third nerve, and about half of the cases leave persistent defect. By this time, we had imaging of this patient. Interestingly, we noted a lesion here in the midbrain, contrast enhancing lesion, the schwannoma involving the third cranial nerve. When we watched the literature, interestingly, another report from our country in 1980s was present. I highly recommend you to read this paper. This was a boy about 50 years old, and we have several imaging was not that the high resolution as we observed today, and the patient was diagnosed during surgery when they were searching the posterior cerebral arteries for aneurysm, and they find the tumor there. Other transient cases have also been reported, and the common denominator in most of these patients is migraine history, and most of these patients have a migraine history in their presentation. What can we give to these patients? In some brain tumors, we give some steroids to decrease the edema and relieve the symptoms. But for this patient, it's safe, especially while he had the conjunctival infection, viral infection. Therefore, we tried indomethacin orally, and his symptoms began to resolve quickly. On the other hand, there are some cases with progressive course. I want to also share with you my study with Dr. Dimmer, my mentor. We had a MRI progressive acquired strabismus were evaluated. Their high resolution MR images were evaluated during this study. The interesting thing is that you see my cursor. Initial negative imaging was really very high in these patients, especially with small tumors and located deep in the orbit. Therefore, it's not rare to underdiagnose these cases. For example, this patient with, let me share. Anyway, you see the atrophic medial rectus muscle here, and the nerve to medial rectus here has a neuroma in the deep orbit, as opposed to normal nerve here, with his adduction deficit on the right eye. Sometimes it's easy to diagnose when there are large lesions like this. They can't be easily missed. Another case with right oculomotor nerve palsy, you see the up gaze, down gaze limitation and adduction limitation of this patient. And you see the neuroma on the right side, which is contrast enhancing nodular region here, typical. Another patient here with contrast enhancing lesion on the abducens nerve and abduction deficit, as you observe here. I hope you can see this side. There is normal nerve. There is again contrast enhanced sagittal region here. So progressive or these are transient clinical course should raise suspicion in our mind. Atrophy of the involved muscle is an important key also. Highly selective clinical involvement of cranial nerves with nodular and fusiform hyperintense neural lesions on magnetic resonance imaging are important for diagnosis. The clinical picture and routine imaging may be misleading in strabismus due to progressive or transient course, as we observe in some patients, involved muscle atrophy, selective cranial nerve involvement, and magnetic resonance images suggest diagnosis of schwannoma. High resolution magnetic resonance imaging is of value, especially in diagnosis. And for transient cases, if you can't use steroids during acute attacks, non-steroidal anti-inflammatory drugs may be useful. Thank you for your listening.
Thank you, Dr. Fatima. The next talk is by Professor Rajesh.
Just a minute. I have to have a couple of questions.
Yes,
please.
Dr. Fatima, what is the percentage of these schwannomas you get, what you have seen? What is the percentage? Because you see, every case of lateral rectus palsy, I mean the abduction deficit, or you have oculomotor problems in the muscles, how would you do MRI in every case? Would you what? So number one, what are the percentage of these? So that if they're very rare, then it's a different thing. The number two question is,
the percentage is not high, but in fact we didn't. I may say about for the initial study that we had done with Dr. Dimmer, in about 600 cases, we observed eight cases. We observed 8 cases. 8 cases in 600 cases.
600 is
and when 8 in 600 cases, about 600 cases. And for the diagnosis, I strongly suggest examining the magnetic resonance imaging of the muscles also, atrophy of the involved muscles, and the clinical course, as we observe in these cases. Subtle progressive or transient course that may sometimes be mixed with recurrent cranial neuropathies, and selective clinical involvement of cranial nerves are clues to diagnose. When we see these signs, we should be suspicious.
Yeah, I got your point.
Go on to imaging.
Dr. Fatima, I got your point. But this is something very new which you have come out, because we don't think of imaging or MRI or doing in every case when we found there is a deficit of movement of the eye. So do you have any specific indication where you think that something of this sort would be there in the orbit or in the brain, and we do go for an MRI? One specific indications where you would suggest to go for an MRI?
I mean, without imaging of the muscle, only clinical, you mean?
Yeah, clinical. Yeah, clinical.
On clinical basis, when I see a transient course in presentation with headache, atypical symptoms, and in some cases with progressive course, for example, we know the third nerve palsy may affect the eyelids, superior rectus, inferior rectus, and medial rectus muscle. But if for example, only medial rectus muscle is involved, as opposed to the other components, we may be suspicious of a neuroma on the nerve to medial rectus muscle. And it depends completely on the clinical picture.
Okay, you mean when there's an isolated muscle involvement of the palsy, we must look into one of these causes.
Yes, and also with the clinical course should raise suspicions.
Okay. Thank you so much for joining us and participating.
Thank you very much. I'm honored to present in this wonderful meeting. Thank you very much.
Thank you very much, and have a good day.
I think so. The progressive nerve palsy or a papilledema in case of sixth nerve should urge us to do a neuroimaging. That's what is the carry home message regarding the sixth nerve palsy. So we move on to the next talk. Next talk is by Professor Rajesh Sinha. He'll be talking on management of the VKC newer paradigms. Welcome, Dr. Namrata, ma'am. Dr. Rajesh, is he here? Professor Rajesh?
Good evening, Namrata.
Hi, sir. Hello, sir. Thank you, sir.
I think Dr. Rajesh, sir, must be busy in some other... I think, ma'am, can we start your presentation by the time?
Sure, Ankur, sure.
Yeah, corneal dystrophies in children.
Yeah, thank you so much for having me. Thank you, SPOSI. It's always a pleasure to be at the SPOSI session. Thank you, Dr. Shreya and Dr. Yogesh Shukla, sir. Whenever sir says anything, it is very difficult to say no. So thank you so much for having me. I would be talking to you about an important topic which was given to me, and that is pediatric corneal dystrophies. And this is important because these children need to be referred fast or referred quickly. So this is a textbook definition where the inherited disorders tend to be bilateral, symmetric, slowly progressive, not related to environmental or systemic factors. And there are exceptions which are there, which I would be talking to you as we go through the presentation. And the IC3D classification, which is the standard classification, was proposed in 2008 and it was updated in 2015. And it has become more objective as opposed to the one which was subjective, because earlier it just looked at the layers, but the genes don't look at the layers. They can involve more than one layer at a given time. So it was categorized based on the identification of the genes and the chromosome rather than the anatomic layer. So primary cell of origin was what was looked into. Anterior segment OCT, electron microscopy, confocal microscopy pictures were also added to it to corroborate the diagnosis. And there were several others which were removed, and I think which would interest more a cornea specialist rather than a pediatric ophthalmologist. So I would keep this presentation as being more basic, focused onto them. So there are various layers which are there, and corneal dystrophies by and large are classified as epithelial and subepithelial dystrophies, which means they'll involve the epithelium or they will involve the epithelium and the stroma. TGF beta 1 dystrophies, or only the stromal dystrophies, or only the endothelial involvement. So category 1 was well defined, well mapped on genes, specific mutations known. Category 2 was which was well defined and mapped on chromosome, but genes were not defined well. Category 3 was defined but not been mapped to any chromosomal locus, and category 4 was suspected, new or previously documented dystrophy, and evidence for it being distinct entity is not convincing. So there can be epithelial, subepithelial complex, which was taken as one. So you can have various types, and I think I will show the pictures so that it becomes clear. Suffice it to say that all these epithelial or subepithelial corneal dystrophies will have similar symptoms, which would be that they will present in early childhood. There'll be recurrent pain, which will attacks will generally occur in the night, will last for 1 to 7 days. There may be diminution of vision if they are recurrent attacks, so they may lead to scarring, and they do reduce in severity as the child gets older. Signs would be recurrent epithelial erosions and epithelial scarring. So this is somewhat what it will look like, with recurrent epithelial erosions and diffuse central haze, which may be there because of repeated scarring. Then subepithelial mucinous corneal dystrophy also will present with the same features. Only thing is that these opacities will be a little deeper. So we did not have any clinical photo to substantiate. So this has been taken from the classic photo, which has been described in the I3CD classification. Then you can have Meesman's corneal dystrophy. Usually it is asymptomatic, but again, it may have painful recurrent erosions at times. And important thing is that it is there in the intraepithelial area. It is not there. It is not there in the central area, or not there in the not a circular kind of a haze, but it is there in an intrapalpable area with intraepithelial vesicles. So it will look something like this. Rather than being in the center, which I showed you previously, it will look something like this. On the retro illumination, you will see these dots which are present. Intraepithelial cysts will be present like this on your histopath, and same will be corroborating on the confo scan. So this is what the new classification has done. Everything, all they have put into one, and there's also a ASOCT picture, which of course in this case is not important because it is only at the level of the epithelium. Then you have Lish epithelial corneal dystrophy. Important thing about Lish is that it can have patterns. So it can be whorl, radial, band-shaped, etc. So again, involvement of the epithelium, but in various patterns it can present. And again, light microscopy will show that PAS positive features are present in the epithelium. And so involvement of the epithelial layers can also be seen on the confo scan. Then gelatinous drop dystrophy is important because it is slightly different. It tends to be more severe. It stains with fluorescein. There may be nodules. So the nodules tend to be a little elevated. And in the end stage, there may be stromal scarring. So there are nodules which are present. It is more severe. More, not only is it symptomatic, but also it may affect the vision. And as it progresses, you can get something like this: stromal opacification and vascularization, which will not occur in the previous epithelial dystrophies that I showed you. And it has massive amyloid in the subepithelial region, which can be picked up on the histopath. Now, then you can have epithelial stromal or stromal dystrophy, which could be TGF beta 1 or beta 1, which will be present in the second type. Again, there will be recurrent pain and there will be diminution of vision. So when there is pain, which is more, it is epithelial. When there is diminution of vision, which is more, then it is epithelial stromal dystrophy. And then you will have something like this. These are geographical opacities which are present, and then they may coalesce with each other, may even reach up to the limbus. And the histopath would show sheet-like layer of, granular mason trichrome red deposits which will stain with it. Then another important one is Thiel-Benke corneal dystrophy, which will again have recurrent pain with multiple flecks with reticular formation, which can be seen here. And this is a very common picture which we come across, but probably we don't diagnose it. Thiel-Benke is like honeycomb. So anything that is honeycomb is Thiel-Benke dystrophy. And again, if you do the histopath and electron microscopy, you will see curly collagen fibers, and you will also see this sawtooth kind of a appearance, which is there. Then you can have granular dystrophy, and the best way to identify granular dystrophy is a popcorn appearance. So it will show that it's like this, like somebody has put popcorn in the eye. This is granular dystrophy. Important thing is that the intervening areas are clear. So between the popcorn and the cornea is clear, but the rest of it is like a popcorn picture, which could be brownish or could be whitish in color. Then again, this is granular dystrophy, stellate shaped, or it can be dendritic stromal opacity also. And then hyaline will be present in the light microscopy. And lattice dystrophy will be having lattice lines, which you can see here. Lattice lines even seen on the retroillumination in advanced cases. And amyloid is there as a deposit. Then important thing is you have to differentiate macular corneal dystrophy from granular dystrophy. Granular is popcorn with intervening area which is clear, and macular is, you can see that it looks like those whitish opacities, but the intervening area is also hazy. So that means it has gone deeper, and it is macular dystrophy and not granular. Granular tends to be more superficial. And classically, the limbus would be spared in cases of granular dystrophy, unlike in macular, where these opacities will go also towards the limbus. And if you look at the light microscopy, and if you look at the histopath, it will show that the Descemet's membrane and the endothelium is involved in these cases. Then you can have congenital stromal corneal dystrophy, such as this, very rare. I have also seen hardly a few cases of stromal dystrophy. Then you can have fleck corneal dystrophy, flecks which are there onto the cornea, dandruff-like picture. So you have to name them differently so that you immediately remember when you see them. So dandruff is like fleck, so fleck dystrophy is dandruff-like picture. And then you can have this central cloudy dystrophy of Francois, which is very much like your posterior crocodile chagrin. Only thing is it will appear in the younger age group. It will appear in children and not in the elderly. So this also can be there, and usually it is asymptomatic and not much loss of vision is also there. So you really don't have to do anything about it. Then, of course, there can be endothelial dystrophies like posterior polymorphous PPCD, congenital endothelial corneal dystrophy, CHED or X-linked endothelial dystrophy. So, posterior polymorphous corneal dystrophy looks like this. So, the posterior part has a metal beaten appearance. So, you just have to remember, actually, for general ophthalmologist, only one feature, and then you look at it and you would just know what you're looking at. And CHED, of course, looks like this with ground glass appearance again, very hazy cornea involving the posterior part, thickened cornea, and Descemet's membrane is thickened, and it's a complete blank. It's a washout, no endothelial cells. So it's like a shocked Descemet's membrane, no endothelial cells present at all. And this is again very rare. I've seen very few cases of X-linked endothelial dystrophy. Looks like this. Important thing is that in all these dystrophies, you have to do a depth of involvement, slit lamp examination, a UBM, and anterior segment OCT, a confocal scan if it is possible. If you're planning some procedure, then fundus evaluation and ultrasound. And if you're planning a corneal surgery, then light microscopy, electron microscopy has to be done. So if they are symptomatic, then they have to be treated medically or surgically. If they are asymptomatic, then they can be just observed. Important thing when you have epithelial stromal and stromal dystrophies, that you have to give lubricants, do refraction. You may have to do epithelial debridement and BCL for recurrent erosions. Some people also like to do PTK for recurrent erosions, and goggles may be given conservatively for photophobia and glare. So I'm putting this slide because most dystrophies would, require this, especially if they are superficial. So surgery will be indicated for symptomatic relief, and the complaints are very severe. And you may do surgery depending on what the level of the opacity is. The various corneal transplantation procedures may be done. So PTK you would do for less than 100 microns of corneal involvement, and for all these dystrophies, which I've already discussed with you, residual should be at least 300 microns, and this is just to show how PTK is done with alcohol, which removes the epithelium and the area of the epithelial erosions with it. And then following this, the PTK can be done, which is up to 100 microns or 50 to 100 microns, and this causes the recurrent erosions to subside. Just this simple procedure. Then you may have to do superficial anterior lamellar keratoplasty, that is SALC. So only the superficial part of the cornea is removed, such as in this case. So this cornea is taken, it is split. So you remove only about say 100 or 150 microns of the cornea. And this is a case in which spheroidal case in which lipoidal degeneration is also there. So this part of the very superficial cornea is taken, and then this is glued and not sutured. So you can see here on the intrapositive microscope that it gets stuck to the back of the cornea. Then for deeper cases, you may have to do deep anterior lamellar keratoplasty, which is the gold standard. And this is just one simple technique to show how we do it. Air bubble is instilled at 90% depth, so your Descemet's membrane falls back. This is an inverted image, of course, and as you give a nick in the overlying stromal layers, your air bubble comes out. And just see how in a live show, the Descemet's membrane is marching towards the overlying stromal layers. So you are still extraocular, you've not entered the eye at all, and subsequently the viscoelastic is instilled. And on the bare Descemet's membrane, the overlying stromal layers are removed, and this is the donor cornea, which is then sutured and which clears over a period of time. This is a case of DALC and a case of macular corneal dystrophy. And then for endothelial dystrophies, of course, you have to do the DSEC procedure. And this is the last video to show how DSEC is done for CHED patients. So you do trypan blue staining. Descemet's membrane is removed. Very difficult to see because of hazy corneas. This is removed. Tags are removed. This is the graft which is taken. Then this is placed inside, and this gets stuck to the back of the cornea. This is, I'll just show you the pictures. So this is how it clears up over a period of time. No chances of graft rejection because you're not doing a PK, and the graft looks clear, and very thin graft is present at the back. And this clears increasingly as time passes. So, and of course, when all the layers are involved, you will have to do a full thickness penetrating keratoplasty. So DMEC, we are very rarely doing now. Post-operatively, they all have to be rehabilitated by refraction, amblyopia management, glaucoma management, and regular follow-ups for higher risk for graft failure in case you have done pediatric keratoplasties. So thank you very much for your kind attention, and thank you for this great opportunity.
Thank you, ma'am, for showing us various procedures and various types of corneal dystrophies we should be knowing of. Dr. Rajesh, I guess, is busy with another webinar. So I'll be asking Professor Niba Anand to deliver her talk on...
By the time Dr. Niba can upload her presentation, and Dr. Namrata ma'am, I just wanted to ask if you find any dystrophy, just little more than 100 microns. So there, even if you do PTK, we leave some of the opacity. So what do you do in that particular patients?
Case the opacities are present in the paracentral area and not involving the visual axis, like those granular opacities, etc., you can still leave it there. You only have to take care of the central 3 millimeter area, which is clear. And sometimes you may not get the patient to come to 6.6, but if the patient comes to 6.18 or comes to 6.12, 6.9, even that itself is a good outcome. So basically, the peripheral part of the opacity, if you're not able to clear, they are slightly deeper, it doesn't matter. You can still go ahead and do your go ahead and do your procedure.
Thank you.
Yeah, we can see the slides, Dr. Niba. I think you can start your presentation, ma'am.
Yeah, just 1 minute. Am I audible?
Yeah, sure. Absolutely clear.
Okay, can you just hold on for a second? Yeah, now is it, am I sharing my screen? Is it visible also?
Yes, ma'am. Yes, ma'am.
Okay.
Very much.
So I'll be talking about factors influencing myopia progression. We know that myopia nowadays has become very prevalent all over globally. So this is just an insight into the factors which are influencing the myopia progression. Now, this is an emerging public health problem in both urban and rural school-going adolescents in India as well as globally. By 2050, it is estimated that approximately 5 billion people worldwide will be myopic. Now, although the refractive errors can be corrected easily, but myopes, particularly those with high myopia, they are susceptible to potentially blinding eye diseases later in life. So, identifying a patient at risk of myopia and active early what do you call acting early can help prevent or delay progression of myopia. Now, there are various theories of progression of myopia, and the most accepted theories are: one is the first theory is the accommodative lag theory, then mechanical tension theory, which has a role of ciliary body and choroid. Then there's a theory of peripheral refraction defocus. This is the most popular currently a theory which is being accepted and um for this. Now, the first theory is lag of accommodation. It says that there's a high lag of accommodation during near work, which causes foveal hyperopic retinal blur. This induces an abnormal axial growth of the eye, leading to myopia. Now, this is supported by the fact that myopes, they have a reduced accommodative response compared to emmetropes, thus an insufficient accommodative response to blur. Such hypothesis suggests that treating myopic children with plus lenses for near work, like bifocals and progressive addition spectacles to reduce the accommodative lag, it decreases the hyperopic foveal blur, the axial elongation, and ultimately myopic progression. So that is why we are nowadays treating one of the treatment modalities for progression of myopia is to give bifocals to patients in young age when they are myopic. Then we have another theory that is known as the mechanical tension theory. They say that eye responds to transient changes in axial length following short periods of accommodation. So whenever during accommodation there's a contraction of the ciliary muscle, it results in a forward and inward pulling of the choroid. The ciliary choroidal tension, it restricts the equatorial growth of the eye. It decreases the circumference of the sclera, leading to a more prolate eye shape and ultimately to an elongation of the eyeball, leading on to myopia. The third theory, which is most currently accepted nowadays, is the peripheral refraction. Now, the peripheral hyperopic defocus, it has been suggested to play a significant role in development of myopia. What happens is that because of the oblong shape of the eyeball, the peripheral rays of light, they do not focus on the retina. So the resulting hyperopic defocus, it serves as a stimulus for growth of the eyeball. Several meta-analysis reports, they have reported a significant reduction of myopia progression with treatments that reduce the peripheral hyperopic defocus, that is orthokeratology and center distance multifocal soft contact lenses, all establishing that this theory of the peripheral defocus might be and might act on the myopia progression. Now, despite a plethora of myopia research, the molecular or the cellular mechanisms which are underlying the development of myopia, they are not well understood. So it prevents the search for the most effective myopia control. So before the myopia control, we should also know about what are the factors which affect the myopia progression. Because once the myopia occurs, definitely the progression, in many patients, the progression of the myopia occurs, leading on to so many blinding complications. Now, these can be grouped into genetic factors. Role of ethnicity is definitely there. Then environmental factors like decreased outdoor activities of children. Then accommodative or vergence factors like excessive near work, which is in reading in high literate patients and also in high accommodation. And also when there's an increased screen time. And the last is the peripheral retinal hyperopic defocus. So all these factors, they are known to be causing the increase in the incidence of myopia and also progression of myopia. Now, we know that around 39 genetic loci have been identified in the human genome, which may be associated with refractive error and myopia. The Sydney myopia study found that the influence of one myopic parent leads to double the risk of having myopia, while having two myopic parents increase that risk by 8 times. Then definitely it is seen very highly prevalent in Asians, Caucasians, and Hispanics, most prevalent in East Asia. It is estimated that approximately 96.5% of 19-year-old males in South Korea, they have myopia. It has a lower prevalence in whites and African Americans. And when we see the rural versus urban population, it is more common in urban community as compared to a rural community. A recent systematic review and meta-analysis conducted in India in 2020 by Agarwal et al. Showed a significant increase in prevalence of myopia in rural children from 4.6% to 6.8%, reflecting a changing rural environment. The study also showed that the highest prevalence of myopia is in the 11 to 15 years of age group in India. Then higher education level, higher achievement and earlier schooling, they're also found to be associated with an increase in myopia prevalence, again, because there is increased near work, increased screen work, and more accommodation, hence leading on to maybe possibly the myopia progression. Then we have factors like accommodation or vergence, like in near work. The evidence for a link between the near work and myopia progression, it continues to be reported in a wide range of populations. There are various studies who have studied this relation. The Sydney myopia
But I
study
cannot hear
and the
anything.
Singapore cohort study for the risk factors for myopia, that is a
cannot hear anything from you.
SCORM, concluded that children who
So I'll
read
have to
continuously
restart.
for more than 30 minutes had a higher incidence of myopia. The near work performance at less than 30 centimeter distance, it led to 2.5 times more myopia. And children who read for more than 2 hours per day, they were 1.5 times more likely to have higher myopia. And for every book read per week, the axial length elongation was more by 0.04 millimeter. So how strong is the evidence that near work causes myopia? A meta-analysis which was done by Huan et al. In 2015, this spanned 12 cohort studies, 15 cross-section studies, and included approximately 25,000 children aged between 6 to 18 years, concluded that there was an evidence rating for recommending a reduction in the time spent with reading to reduce the risk of myopia. Now, this suggests that there is a substantial evidence supporting this recommendation. Now, the effect of near work on myopia development appear to be related not only to, only to reading, but not watching television or playing computer games or even studying. But further studies have shown that there is a relation of the digital device and watching television on myopia. There was another study that was a clear study, that is a collaborative longitudinal evaluation of ethnicity and refraction error. This showed that the relationship between the near work and myopia was again directly related. Interestingly, in this study, the differences in the time spent reading, watching TV, playing computer games, and studying only became apparent after the onset of myopia and not before. So basically, they studied whether all these things like the near work, it causes any progression of myopia, where there was seen that there was definitely a direct relationship between that. Then another study which was done, the Beijing Pediatric Eye Study, conducted on around 15,000 school children with a mean age of 13.2 years. They reported that long reading duration, shorter reading distance, watching TV or computer, dim reading illumination, they are significantly associated with myopia. So basically all near work, dim reading and increased screen time, they all show that they are directly linked to myopia incidence and progression of myopia. Now, we know that nowadays children, they are very much hooked to their digital devices. And also in this COVID pandemic, the screen time of all children, it has increased innumerable times. So it may be intuitive to link the digital device usage to increased time spent indoors and on near work, thus conferring an increased risk of myopia onset and progression in children. A large cohort study of around 5,000 children in Rotterdam, that is a Generation Art study, which concluded in 2020. It found an association between increased computer use and myopia at around 9 years of age. The combined effect of near work, the reading distance, including computer use, increased the odds of myopia at around 9 years of age. Again, showing a direct link of increased screen time to myopia and myopia progression. Another study, which was recently concluded by McCrae et al. In 2020, where 418 students were enrolled, they found that the device recorded smartphone data usage, which was used as an objective surrogate for the time spent using the smartphone. This was again independently associated with myopia. Then another theory there says that the peripheral retinal hyperopic defocus, as I told earlier, that because of the oblong shape, the peripheral rays, they do not focus on the retina, the resulting hyperopic defocus, it serves as a stimulus for growth of eyeball. Now this process we know that is important in the e-metropolization process, but however, this may also serve as a stimulus for the axial length elongation. So now Another thing is that nowadays, because the screen time is increased, so there's an decreased outdoor activities. So increased outdoor activities in children, it has shown to protect against myopia onset. A meta-analysis reported a reduction in both incident myopia and prevalent myopia when the outdoor activities, they were increased in these children. He et al. And Wu et al. Both, they showed that an additional 40 minutes of outdoor time per day achieved a 23% reduction in myopia incidence. And similarly, Wu showed that there was a 54% lower risk of myopia progression among both myopic and non-myopic children spending 11 or more hours outdoors per week. Another study which was done also showed a reduced myopic shift within the myopic subgroup of children randomized to the outdoor time intervention as compared to myopic control. So basically, we all know that because the screen time is increasing, the indoor activities are increasing, the outdoor activities are decreasing. So what are we doing? We are basically heading towards a myopia epidemic. Now, because the prevalence of myopia has increased many-fold and it is still increasing, so the World Health Organization has put some guidelines on physical activity, sedentary behavior, and sleep, and it recommends that less than 1 hour of sedentary screen time should be there for children aged 1 to 5 years if we want to stop or at least slow the process of myopia incidence and progression in the world. Governments all over the world have also imposed limits on digital device usage in order to prevent myopia. In China, where nearly half the population has myopia, aggressive government policies have been implemented to combat the myopia epidemic. The culprits identified are and targeted in these policies. They include the heavy study load, use of digital devices, and a lack of outdoor activities. In Taiwan and Singapore, government policies, they are closely integrated within the school education system with respect to incorporation of the outdoor activities during school time. So now we have to be very aware of and beware of all the factors which lead to myopia and myopia progression. Now, just in short, how do you control myopia? The several approaches to slowing down myopia progression in the actively growing eyes of children have been underway. And we can just give a little gist, like we can do with lifestyle modifications, like decreasing the screen time, increasing the outdoor activities, and also corneal reshaping contact lenses like ortho-K lenses are used, multifocal contact lenses, multifocal spectacles, and even eye drops like atropine, they are being used to control the progression of myopia. Thank you.
Thank you, Professor Niba, for such an enlightening talk on myopia. And I'll ask Professor Rajesh to take up the last talk of this session. And thank you, sir, for toggling between the webinars and coming to our straight 2020 here. So Dr. Rajesh will be talking on management of VKC and newer paradigms. Dr. Rajesh, please share your screen, sir.
Thank you. Thank you, Dr. Ankur, and thanks, Posi, for having me here.
Welcome, Rajesh. Welcome.
Thank you, ma'am. Thanks a lot, ma'am. So nice to see you all. And actually, I was in some other thing, and I'm sorry to say, but it had slipped out of my mind. And I really thank Ankur for reminding me. And I will just quickly, do my presentation on vernal keratoconjunctivitis. It is a chronic bilateral seasonal allergic inflammatory disease of eye, which involves both tarsal and bulbar conjunctiva. And it is, the recurrence is the key in this, because the child who develops mostly in the school age group, 4 to 7 years, and it continues till puberty, the child is recurrently having these symptoms of VKCs. That is the hallmark. It is more often seen in the male children. It may be associated with atopy, and it's higher prevalence seen in the Asian countries, the Mediterranean countries, and South America. There are immunological factors involved in it, type 1 immune reaction, IgE-based immune reaction. And then there are certain environmental factors as well, because it gets precipitated by certain environmental factors which carry the allergen. And it does have some genetic factor in it, because if a child is having it, one should definitely rule it out in the sibling. is many times seasonal, but 1/4 of these are perennial, and you have to be really very particular about these perennial cases because these can lead to sequelae that are more dangerous than what exactly is VKC. The symptoms include itching, which can be mild to intense. There can be photophobia, mucoid, ropey discharge, watering, redness, foreign body sensation, and does have a waxing waning course, as I said. And you can get to see these papillary hyperplasia, which enlarges to become giant papillae. There's cobblestoning. There is Horner-Tranter spot, serogerontoxin. All these things lead to stem cell deficiency. And then there is the vascularization of the cornea superficially. And all these things can lead to further complications. It can be bulbar, it can be palpable, it can be mixed variety. And there are various gradings, which I'm not going to go into, but there are various ways of grading. As far as investigation is concerned, many times it is felt that allergic eye disease or allergic diseases can be investigated, and a particular allergen with which a child is very much allergic can be obstructed and can be handled. But practically speaking, it is really next to impossible because the child is not allergic to just one allergen, but there are multiple allergens that are involved, and that is why the immunological tests are not routinely done. Now, a child who is having a long-term, irritation and itching, etc., the child keeps rubbing the eye, then there's risk of development of keratoconus. So a child who comes with VKC should definitely be ruled out. Corneal mapping should be done, ASOCT should be done in order to rule out the sequelae, that is keratoconus. You can have a lot of sequelae, as I said, that, the allergic eye disease is definitely there. It is a nagging thing, but a permanent sequelae, if it occurs in the form of, say, stem cell deficiency in terms of keratoconus, that can have more serious implications. So the complications of the sequelae can be limbal stem cell deficiency, leading to scarring, leading to neovascularization. There can be shield ulcer because of the large cobblestoning of papillae. It causes mechanical rubbing, and that can cause shield ulcer. Then because of repeated use of and long-term use of steroid, it can lead to steroid-induced cataract and glaucoma. There can be ptosis because of rubbing. The LPS becomes weak. Then there can be dry eye. And of course, as I said, as a cornea person, I'm very sensitive to this complication, and that is keratoconus. So as far as management is concerned, the parents hold the key, because all these children, they get a little dissuaded after use of medication for some time, because it requires a long-term therapy. So parent role is very essential. So our role is to counsel the parent. That is most important. And of course, pharmacological therapy is the key. And at times we may require some surgical therapy. As far as the pharmacologic therapy is concerned, mast cell stabilizers or dual acting agent, which we do these days, commonly used these days, other ones that are more often involved, more often used, olopatadine, they can be bifostastine, they can be alcaftadine, epinastine, all these drugs are there. Now, some immunomodulators in the form of cyclosporin or tacrolimus are also very effective. Actually, to tell you frankly, in a case of VKC, if a patient comes to me, I definitely see to it that you cannot use steroid on a long-term basis. So you have to taper it off after some time. But these cyclosporins and tacrolimus, which don't have a very long-term, they can be used with great effect in these patients. Now, topical steroid is very essential in order to reduce the symptoms. And it depends on the severity, what kind of steroid you will use. If it's a mild severity disease, then you will go ahead and use a low potency steroid like chloromethanolone or glutapentine basis. So you have to taper it off for some time. If it's a very severe disease with cobblestoning, etc., in such a scenario, you may have to use a stronger steroid like prednisolone or dexamethasone. And then later on, you can taper it off, substitute it with a slow potency steroid as there's a response. And one has to be very careful when one is using steroid because of the risk of glaucoma and cataract. Now, if by topical medication, things are not working and there's a lot of large cobblestoning, And in that case, supratarsal injection of steroid is very effective. Triamcinolone 20 milligram to 40 milligram, mostly 20 milligram because you use 0.5 ml injection of triamcinolone. Supratarsally, you evert the lid. So you know now that the tarsus margin is here. So you go supratarsal and inject here. You can inject here. And so 2-3 sites you can inject, and then you can expect a resolution. Now, when you're using supratarsal steroid, you should not be discouraged if the response is not very good by first injection, because on an average, what I have felt in cases wherein I have used supratarsal steroid, on an average, 3 injections are needed in these patients to have a good resolution of these cobblestoning, these giant papillae. And during this period, one has to be careful to rule out glaucoma. Excision of giant papillae has been reported in literature with use of amniotic membrane covering the bare area. And sometimes you can have a shield ulcer like this, as I said, because of the mechanical irritation by cobblestoning, because of the large papillae that can result in shield ulcer. So this shield ulcer will resolve by use of amniotic membrane. If there's a plaque, you just need to debride it. Now, if after debriding you get a very deep gutter, then you will have to use a multi-layered AMG to fill the gutter and then an overlay of amniotic membrane. But if the gutter is not too deep, then in that case you can just put an overlay of amniotic membrane, and the management of allergic eye disease has to be continued even after this surgical procedure, because that is essential to control it. So this is the whole algorithm which I have already mentioned. So in summary, in order to cut short, I would say that a combination therapy is essential in order to resolve cases of vernal keratoconjunctivitis. Long-term therapy is needed. So we have to counsel the patients and the parent. The tapering of steroid or the use of appropriate steroid depending upon the severity of disease is very essential. So we have to understand that. Follow-up is essential to rule out complications, to rule out sequelae, to rule out keratoconus, to rule out shield ulcer, etc. And as I mentioned earlier also, parent counseling is very essential to have a good outcome of the management of VKC. Thank you very much for your patient listening. And once again, I thank SPOCI, the whole team of SPOCI, Dr. Shukla, Dr. Ankur.
Thank you. Thank you very much, Rajesh, for joining us. Thank you very much.
Thank you.
Now, Ankur will...
Yes, sir. Thank you, sir. So now we have the next session, which is the special session. And I'm handing over this to the secretary himself, Dr. Shukla, for the further needful. And he'll be taking care of the next session. Thank you, everyone.
Thank you, Ankur. Thank you very much. And now we have finished our scientific programs